Okay, well, I want to welcome all of you to our webinar today, uh, Understanding Children's Mental Health. This is being hosted by Samaritans Suicide Prevention Center in New York City. We are part of the world's oldest and largest suicide prevention network. As the people who run the suicide prevention hotline in New York City, we're very proud that Samaritans created uh, the first suicide prevention hotline in the world almost 70 years ago, and it has spread to countries all over the world. Today is National Children's Mental Health Awareness Day. It's something that was originally created by SAMHSA, the Substance Abuse Mental Health Services Administration, which wanted to create an awareness day to shine a spotlight on the importance of caring for every child's mental health and to reinforce the message that positive mental health is essential to a child's healthy development. The purpose of the day, and there's events going on all over the country, sponsored by government and community agencies and advocacy groups, is to increase public awareness about the needs of children with mental health issues, especially serious mental health illness, and to provide support and information and evidence-based practices, as well as encouragement and validation for the experiences and challenges people face in providing support and care for our young members of our families and communities. Uh, Today, we are going to be focused on a cross-section of aspects tied to children's mental health, and we're very pleased to have our presenters with us. So we have Erik Bottcher, we have Brian Mishara, and Cheryl Hall, who will each give us a unique perspective of issues tied to this event. And I think I'm not going to make many comments to begin, but I want to remind people that yes, children of all ages experience depression, self-harming, and suicidal behavior. And even some of our youngest children attempt and die from suicide. So this is not a theoretical conversation. Uh, if we look at the general population in the country as well as in New York, it was estimated, and these are pre-COVID statistics, that 1 out of 5 Americans, as well as 1 out of 5 New Yorkers, experiences depression or other psychological disorder on an annual basis. As many as 60% of those who experience these disorders never receive help. The latest research from the CDC suggests that there's been a 300% increase in rates of anxiety, a 400% increase in rates of depression, and that suicide ideation has doubled across the population. If we look at our children, ER visits and hospitalizations are up 24% for ages 5 to 11 and up 31% for ages 12 to 17 from the previous year. And when we look at our vulnerable populations, they're racial and ethnic minorities, people living in poverty, immigrants, survivors of sexual assault, intimate family and partner violence, those with substance abuse, members of the LGBTQ community, the elderly, and as we're focusing on today, our youth and children. So this just kind of sets the framework for what we are responding to. And most people, if not all of you who are taking part in this presentation today, have your own experience, whether it's on the job or in schools or in practice or community organizations, with family, friends, and colleagues. This is something that touches all of us both personally and professionally. So I want to introduce our first speaker, Erik Bottcher, who is someone Samaritans knows for many years in his work with the City Council, most recently as the Chief of Staff for Speaker Corey Johnson's office. Erik has been a tremendous advocate for suicide prevention. He's been an advocate for Samaritans, and has been very open about his own experience growing up in dealing with depression and issues that he has faced, and is now as a government and a political a professional is carrying that advocacy even further to bring the importance of this issue to the public, to government, to policy and legislation. So we're so pleased that Erik is taking part today, and I'd like to introduce Erik Bottcher.
Alan, thanks for having me. Really appreciate it.
Yeah. So maybe to get started, let's get rid of that slide, please. To get started, maybe since you've worked both on the advocacy level and in government policy, when we look at something, you know, there's so many days that have labels to them, and sometimes we can lose our focus with all of these different areas of emphasis. But from your perspective, why is Children's Mental Health Awareness Day so significant?
Well, again, thanks for having me, Alan. This conversation couldn't be more important, and those statistics that you read off earlier are so disturbing and highlight why this day is so important. It was important before the events of the last year, but now it's so very important. And I think that as a society, in the last few years, it seems like we're starting to recognize mental health care as healthcare, and recognize the importance of it, particularly for children, but we have a lot farther to go. And, you know, what's happened over the last year, I don't think we even know the full impact of what the last year is yet. From an educational perspective, from a social perspective, emotional perspective, what will the effects of this have been on this generation of young children? So I think that we all need to focus on the youth, on mental health care and the youth and young people. And that's what this day and conversations like this will help us do.
Right. I have a colleague who's an epidemiologist, and he was pointing to the fact that, you know, we can look at 9/11 as a national traumatic event, and that from a psychology, emotional support level and manifestation of trauma, that it was really 1, 2, 3 years before we really started to see the impact of these devastating lifetime events. So it seems that unfortunately, we're just beginning to start, as we start to come back to some semblance of normalcy, see what we're going to have to respond to. Now, you've been very open in your advocacy work, in your political work, about your own experiences in life and growing up and what it was like for you. Maybe you could share in a way that obviously is comfortable for you now that you have the adult professional perspective of, you know, what was that experience of being a child, an adolescent, dealing with emotional difficulties and challenges, and maybe undiagnosed kinds of issues, and you know, just from a way that brings the reality of that experience to our audience.
Sure. Well, my story and my family's experience was like millions of others, and probably like many that those of you watching have seen. As a young person growing up, I grew up in a small town outside of Lake Placid, New York, in the Adirondack Mountains, Wilmington, New York, a population of 1,100, a beautiful area. My mom and dad had a fly fishing motel on the Au Sable River called the Hungry Trout. My dad worked the front desk. My mom was a hostess in the restaurant. And it was a great childhood. But when I reached adolescence, I began suffering from depression and the realization that I was different, that I could be gay. And that was a different time as well. That was in the early 90s, 1991, 1992. There were no role models on television then. There was no internet to meet or talk to other people who were going through this. So I felt that I was the only person in the world going through this, and that nothing would ever get better. And I distinctly remember thinking that I just wanted to go to sleep and not wake up again. That was the answer for me. And I tried to end my own life on a number of occasions. The last attempt, after the last attempt, I was sent to Four Winds Hospital in upstate New York, where I spent a month there. And when I got there, I was there with young people from all over New York State, from Buffalo to New York City. And these were young people who were recovering from sexual abuse, physical abuse, drug, substance use, gang involvement. So here I am, this kid from the middle of nowhere, really making actually very close friendships to other young people who were going through things that were, actually much worse than what I was going through. Um, and that saved my life. The treatment that I got there, there was still a rough road ahead, but that between being on antidepressants and the individual therapy, the family therapy, and years of individual therapy, and I still am on antidepressants today. I didn't realize then, but I realized it wasn't until later that I recognized how fortunate I was to have that treatment that so many others do not get. And, particularly people of color, people living near or below the poverty line. I am just so fortunate that I was able to get that kind of treatment. And I believe we need to fight to make that available to all young people. And it's not. 30 years later, it's not. And we could alleviate so much suffering, not just saving the lives of young people who were losing, but alleviate so much suffering among the families. Every time we lose someone, it's multiple lives that are destroyed. So we have to do better.
As you look back and can reflect on what it was like as a young person, we do an exercise in hotline training, with sensitivity exercise, where we have people go back and go, when you were depressed, when you were overwhelmed, and you reached out for help, what turned you off? What shut you down? What made you regret seeking help? As you look back, what did people not see? What did they miss? What did they avoid? And it doesn't mean they weren't loving people or caring people, but what was it they just didn't get?
It's interesting, and I'm not a parent, but I I really have a lot of respect for parents, because how do you distinguish between the teen just being a teen, like sulking in the bedroom, like all kids do, with like depression? And how do you know when it's uh, at a serious level? And um, I don't know if my parents, I don't know if I gave them reason to really suspect that I was, you know, making attempts to end my life. Or if I was just being you know, a withdrawn kid. So that's where I think mental health professionals really come into play. I think having mental health professionals in the school environment connected with primary care. You know, it's the primary care physician that asks, like, how are you doing? And knows what to look for to make a referral, to have an additional conversation, or the school counselor or the teacher knowing what signs to look for to make that referral. You know, that I could have gotten help earlier potentially.
What do you wish someone, again, these are all, and it's a great ability to be where you are today and have had the experience you had. And, you know, that experience does enlighten us, or it does program us to have some awareness of what it was like. We've been talking a lot lately, going back about unbecoming a person, Rogers' active listening. And in one of his essays, he says, therapists should put themselves in the other person's shoes and not focus so much on what they think or feel. What could someone have said, or what might have opened a door that didn't?
I don't know the answer to that. I don't know the answer to that. All I can say is that when I was taken to the hospital, the right things happened, and I wanted to go home. They said, you're not going home. You're going to this place. I said, I don't want to go. They said, you don't have a choice. And when I was there, the treatment was what I needed. And I think being around other young people who were also going through tough times, I think that really helped me a lot, gave me a lot of perspective. What could have, you know, I think one thing I would say is that, you know, from an LGBTQ perspective, if I had even known LGBTQ adults in town, I found out later that there were actually quite a few, you know, and that town actually elected a lesbian town supervisor like 10 years later.
Right.
So that kind of thing would have helped. But, you know, just the feeling of being the only one and just not wanting to deal with it, that just having other people in knowing there are other people in the world would have helped me.
One of the most common questions we've had, and Samaritans has been doing professional development training for 30 some odd years. And I think one of the most significant questions we're always asked by counselors, psychologists, and therapists is the very difficult challenge they have in talking to parents of young people who are having difficulties and challenges. And again, I know my questions require some kind of projection or creative thinking, so to speak. But if you had any feedback or advice to give, because, you know, counselors will say the student's behavior is just, you know, so clear, and then you talk to the parent and they're in denial, or they get angry, or they blame the counselor. So in any way that, again, you feel is responsive, what ways or what thoughts do you have about how someone can approach a parent when it's become obvious in a school or community health setting that the young person is having mental health challenges or difficulties?
It's a really good question. All I can say is that my folks were great, and I'm so lucky that they were just unconditionally supportive. And I was horrible to them, like most teenagers. This is your fault. If you had just, made me play sports when I was younger, I wouldn't be in this. I said horrible things while they came. They drove the 3 hours to come for the family therapy, and I was awful to them, but they were just unconditionally loving. And um, I didn't uh, so I didn't have yeah, I was very lucky that way.
Right. Right. I blame my parents for making me play sports. So, I could work.
They
You
did try to they did try to make me play sports, which is the funny thing.
right.
And I didn't I wouldn't do it. Now I would love to. Now I always joke that, when I'm at the gym, I always joke that, God, we're spending all this money to go to the gym when they had to drag me to gym class when I was a kid. Now I'm spending all this money to go.
Just to kind of close and give you the opportunity to share what you think is important or what you'd like people to think about, whether again they're a lay person, a caregiver, a volunteer like Samaritans, as well as mental health professionals, people working in the schools. Well, what if you had to say, these are a few things that we want to think about, or it might be helpful to think. One, as you were talking, I was reminded we say in Samaritan's Hotline training, we steal ideas from all schools of thought, and we talk about in conflict resolution. It always says separate the person from the problem. So as you're describing this behavior, but that's not the young man. That's the manifestation of the behavior. Uh, what would you suggest that people think about when they're responding to a young person whose behavior, like you're saying, I was a horrific adolescent, and to my knowledge, it wasn't due to a mental health problem. It was just I was a pain in the butt. And I've been transplanted from Texas to New York, and I never got over my anger about having that happen to me. But the manifestation of my behavior was pretty horrific, and I got arrested and all these terrible things. So it would have been hard to distinguish. Today, I probably would get a different kind of psych eval. What is the takeaway, or what would you like people to think about as they're responding to a situation where you never know exactly what you're dealing with?
To help someone see the possibilities that the future holds, the potential that the future holds, the light at the end of the tunnel. If, I never in my wildest dreams would have imagined that I'd be living in New York City, that I'd be working for the governor of the state of New York, the speaker of the city council, or that I'd be a candidate for city council and possibly a member of the city council of New York. I just never it would have been inconceivable to me. And, the challenge is, how do you get someone to transcend the current moment that they're in and look past it and see what the future holds? The problem is that depression and mental health challenges, they don't have a logic to them. It doesn't matter what pot of gold is there. You won't see it, and you feel the now. But, to me, it was, in addition to all the help I got, it was seeing that high school graduation was approaching. So helping young people, particularly young people who probably haven't been told before that they can be anything they want to be, their wildest dreams are possible, and showing them that. I would think that that would be something that would help young people a lot.
Well, I really want to thank you for taking the time. As I mentioned, you've been a great friend and supporter of suicide prevention and mental health in New York, especially for Samaritans. We can't take political stands, but boy, we'd love to have you in a position where you could be making some of these decisions a little differently than they've been made before, and I'll keep it diplomatically at that. But we're wishing you all the best. We thank you so much for taking time to join us today, and we look forward to working with you in the future. Thank you so much, Erik, for taking the time.
Thank you, Alan. Take care, everybody.
So I next want to introduce Brian Mishara. Brian, again, is an old friend of Samaritans, has been involved in suicide prevention on every level, on an international level, on a national level, through his work in Montreal. And I have to say, of all the professionals I've come in contact with and worked with over the years, I have found that Brian has presented a clarity and a focus that really helps to make this issue palpable, and also giving us, practical lessons and understanding of how important it is to take a young person's mental health seriously. We had a presentation, I can't even remember how many years ago, 4 or 5 years ago, I think, on children and suicide. And when Brian presented on the fact that, yes, 5, 6, 7-year-olds attempt suicide, the audience of 300 mental health professionals, there was almost a gasp in the room. But Brian's done groundbreaking work in this area, as well as in suicide prevention hotlines and so many different issues, more than can be discussed here. But we're so pleased that he took time to join us. And I think that the information and the perspective he provides for us is so valuable. And I hope you'll give it the utmost attention. Brian Mishara.
Thank you, Alan, for the introduction. What I'd like to do, and I'm going to try to share my screen and see if that works. And I'm going to talk to you about children and suicide. I've been doing some studies where we talk to children about death and suicide. Children think a little differently. It takes a while to develop the type of understanding of things that adults have. And I think it might be useful to have a look at what children understand about suicide. And in general, we can start about what children think about what's alive. The psychologist Jean Piaget, a long time ago, started interviewing children to try to figure out how do they know what's alive and what's dead. And basically, the youngest children think that things that move on their own are alive, and things that don't move are dead. So a car is driven, so that's not alive. But a cloud's pretty problematic for children 5, 6, and 7 because it seems to move by itself. After the Second World War, a lot of fathers died. And people wanted to know, well, how does this affect children? And what do they understand about death? And basically, they discovered that what we understand about death as adults is different from the youngest children. And young children don't have a sense that death is final. It's sort of like in the cartoons, someone gets squashed by a steamroller and comes back to life. the idea that everyone's going to die, it just doesn't make much sense, because if you have a good doctor or you're in good health, you're not going to die if you eat well and do the things kids have. And also the idea that death is irreversible, that once you're dead, that's it. You don't come back, and that we're all going to die, whether we like it or not. And that somehow, if we die, it's not going to be because we didn't do the right thing, or we didn't eat the right food, or we exposed ourselves to COVID or something like that, that there's something about being human that means that we're going to die. These are all what we could call mature concepts of death. Children talk about death as easily as we talk about what's your favorite type of pizza. We only start getting concerned about talking about death when we become teenagers and adults. Children like to experiment about death. They might do little experiments with ants about what happens when they get killed, or they're very curious, but they pick up on adults. So if you want to talk about death with a child, you talk about it like you talk about pizza, and the kids pick up on it, and they'll talk about what they think and feel. But if you are hesitant yourself in asking the questions, or you're a little anxious, then they'll pick up on it, and they might sort of avoid answering you. And when you talk about things like this and try to figure out what children understand, you need to really probe a little bit. So you might say, when you're dead, can you see? And child says, no, you can't see when you're dead. And you figure, wow, that's a nice mature concept. And then you say, why not? And said, well, it's dark in the coffin. There's no light. And I said, well, what if you put a flashlight or something in the coffin? They, oh yeah, then they could see just fine. So you have to probe a little bit. Also, children have an amazing characteristic. They have the ability to believe two or more contradictory things at the same time with no problem. So you say, when you're dead, can you see what's happening on Earth in your family? Say, no, when you're dead, you're dead. You can't see anything. Your eyes don't work anymore. And then a little later, we're talking about, do you know anyone who died, and your grandfather died? And the child says, grandpa is very happy to see that I got a good grades today in my math exam. And then you say, but you said, when you're dead, you can't see. And said, yeah. And you just said that grandpa saw that you got good grades and saw your report card. And he said, yeah. And it looks at me like, what's your problem? This is an adult problem. Being for children, you can believe contradictory things. We're talking about young children, 4, 5, 6, 7 years old. So one of the things that I've done, and some of this is published, and we asked children about suicide. Now, the word suicide is something, it's a big word, and a lot of children don't pick up on that word. Usually in America, around age 7 or so, some 6, 7, and 8, the word suicide. But children know about people killing themselves. And if you ask, how can you kill yourself? They name all sorts of things like hanging and shooting yourself and things like that. By age 6, 7, they can name quite a few of them. The only interesting thing is they add to the list some being hit by a car. And that's very interesting because that's one of the most common causes of accidental deaths in children, and they're almost never listed as suicides. And if you ask children why they kill themselves, they don't usually until much later, and even up through adolescence, have much of a sense of it. But they often refer to some suicide that they have seen. Children have experiences with suicide, and I'll tell you about them in a minute. And basically, they don't think it's a good thing to do. It's very rare that any child says it was good, right, or okay. And how do children learn about suicide? They learn by television and children's films. There's suicides in Bugs Bunny cartoons. There's a great suicide threat in a Bugs Bunny cartoon. Porky Pig has a big carrot, and Bugs Bunny comes along, says, "I'm really starving. Can I have the carrot?" And Porky Pig says, "No, this is for me. It's my carrot. You're not going to get my carrot no matter what you do." And Bugs Bunny says, "Well, you don't understand. I'm desperately hungry. I need that carrot." Porky says, "You're not going to get this carrot this time. It's all mine." And Bugs takes out a gun and he puts it to his head and says, "If you don't give me the carrot, I'm going to kill myself." Pig says, "Yeah, you're just joking. You wouldn't do it." He says, "I will, I will, I will." The pig starts crying and he gives Bugs Bunny the carrot. He eats the whole thing. And then he takes the gun, he pulls the trigger, and a flag comes down with the word bang, and he laughs and runs off. So what does that teach a child about suicide or threatening suicide? Many Walt Disney films have suicide. In The Incredibles, there's the superheroes save someone who jumps off of a building and then they sue him for stopping him from killing himself. Children are exposed to suicides in fiction. When suicides occur and adults talk about it, they listen and often understand, but adults almost never talk with children about suicide. Children rarely commit suicide. It's really a phenomenon that starts at adolescence. Adolescence is starting a little earlier now. So it's not 14 or it's going down. There's more 13 and 12-year-olds, but it's pretty rare. But the numbers may be underestimated. Some people might classify children's suicides as accidents. And either the rates are increasing a bit or we're being more open to identifying children's suicides. They're still pretty rare. It doesn't mean that children aren't concerned about suicide and talk about it. And the way children think of suicide is different. Adults who are being suicidal feel I can't go on suffering like this. But children, they don't have such a sense of the future. It's more like I'm suffering right now. I can't stand it. The suffering will never end. And children don't think about the future when they're suffering. It's just, I am who I am, and that's how I'm going to be. And adults might think I can kill myself and I can know how to do it. And children just get focused on a certain thing that they feel is the way to do it. adults might think, and you see this in suicide notes sometimes, that others will be better off afterwards. And children feel, I'll be happier afterwards, because their concept of death is that once you're dead, you're sort of like you're alive, except you're in another state dead. So you can see and hear and feel things afterwards. And the idea that somehow it's a final, it's over, your life's over, is something children often don't think about. And I think I don't have a lot of time, but children are more impulsive very often, and some adults are impulsive. There are impulsive suicides. With adults, usually there's some sort of mental health problem associated with suicide. With children, usually you can't diagnose anything really. It's not easy to find a mental health problem, but there's a lot of immature or magical thinking, or feeling overwhelmed by emotions like guilt or shame or anger. And I'm gonna just,
Brian, take the time you need. You don't need to rush. Take your time.
okay, I'll take some time then. I was trying to stick to like 30 minutes and have maybe some possibility of questions, but like adults, children's, if you want to know if a child's suicidal, the best way is to ask them, and we'll talk about talking with children in a little while. But children who threaten suicide, they need to talk about it. If someone says, I'm going to go kill myself, it's not something to laugh off or something, or sometimes I think everyone would like it if I just disappeared. Those are the sorts of things. What's going on? What are you thinking about? Another thing is children who are interested in methods. That's something which you should worry about. A child who's making nooses, or playing with knives or things like that. Any sort of planning. And the sorts of things that you find are signs of depression in children, which is not so easy. But besides sadness, monotone voice or being unemotional is often a sign of depression in children. Difficulty concentrating, schoolwork, being tired, stomach pains, anorexia, anxious, not participating in things the child usually participated in, avoiding answering questions or long delays or other difficulties and so forth. They're all signs something might be going on and it's worth investigating. Um, how to talk about suicide? Whenever you think that, Jane just said something that sounded like she was talking about suicide or concerned about that or unhappy or depressed, but generally she seems fine. There's no reason to bring it up. Whenever you hear that little voice say that, that means you absolutely have to talk about it. There's no harm. I've talked to hundreds of children about death and suicide. I've never had a child say, oh, suicide. I wasn't thinking about that. Now you mention it, I think I might want to do that. It never happens. Children are usually relieved to talk about this because they're exposed to it. They know about it. They've seen it in Walt Disney and in cartoons. This is nothing new. And to have an adult talk about it is really fabulous. But when you talk about suicide, you have to start with what children think and believe. So it's not children don't need to be told much. That you have to understand after having a trusting ask what they think about what they're planning, what they're thinking about. You have to ask children what they think about death. Children very often have some odd ideas about what it's going to be like after you're dead. Most common being that I'll be really happy then, and I'll be happy to see how this affects other people. And this is something you need to correct. And you can correct it right down to age 5 or sometimes even younger and say, no, you're going to be dead. You're not going to be playing and happy and smiling. Those are things you do when you're alive. And sometimes this is quite shocking for someone who is thinking about suicide. How people will feel if they kill themselves. So a child says, I'm going to just run out in front of a car and I'll die. How does it feel to be hit by a car? If I hit you a little bit, would would it hurt? What if a big car hit you? These are things you may not think about. Who knows about it? Who do you talk to? Children talk to other children about these things and make them promise not to tell. And, and children who are concerned, if they're talking to you and don't tell my parents, they'll be upset with me. You got to involve the parents and you have to educate them a little bit about, talk to it, and describe the reality of death. Children can learn that death means being dead, not being happy and playing and seeing and so forth, and suicide. The other thing is with children, you've got to just say, don't do it. It seems so simple, but very often, particularly therapists, they think, you don't tell people what to do or not do, it's their right, and so forth. An adult who someone trusts that says, that's not a good way to straighten out things. You're not going to be better off then. You're going to be dead. Let's find some other ways to deal with things. Don't do it. Something to add, and you have to be available. Look, if you're feeling down or something, call me and listen to understanding, to the suffering, communicate understanding. That's obvious in building hope, and that's something I cut out of this, but there are ways of building hope. I wanted to say something about children where there's a suicide in the family. Children almost always know. They won't admit it if they think that you don't want them to know. But when a father, a brother, a family member, a neighbor died by suicide, most of the time children know about this. But they learn very quickly that there are people who think they shouldn't know, so they should pretend that they don't know. They overhear conversations and they talk with other children at school. So when dad killed himself, chances are other children will hear their parents talking about this, and they'll say something. Then they'll say, no, he didn't. And then go home and say something to the parents who will deny it. But other children usually tell them. If they have a phone, they get a text message about it or talk, and they overhear conversations. And those who are never told get very angry and upset when they don't find out until they're an adult. You see them in psychotherapy for years. This is not, you think you're protecting a child, but at some point they're going to find out. And boy, are they going to be messed up by this. So I think it's important to talk about it, because the chances are they're going to find out. They're going to find out anyway. And if you don't talk about it, there's a danger. And the danger is that children often feel responsible and guilty. Anyone who loses someone by suicide feels responsible and guilty, but children can really take it to heart, and this can really mess them up. And if no one talks about it and tells them, you had nothing to do with it, it's not your fault, that this person, your father, your brother, was having problems that had nothing to do with you. If you were a better son, your mother, that wouldn't have impacted it. You were a wonderful son, and your mother, is probably very, very sad to have done that. But you have to directly convince the child that he or she is not responsible. And if you don't discuss it, children often have this burden of feeling, if I was a better son, if I was a better brother, I should have known and done something about my friend. And the only way around this is to have an opportunity to talk about it. I have seen so many instances where a child has discovered the corpse of someone who died by suicide, who has walked in and seen a brother hanging in the room. And then the parents explain that it was an accident and it wasn't a suicide, or the person died of a heart attack or something like that. The child knows, and they need an opportunity to talk about all this. Adults are much more afraid of corpses than children are. They're very curious. And we're talking about guilt. I think we said enough about that. The other thing is that children are often angry. And this is not a nice feeling to have, because adults don't like it when a child is angry at mother, father, or brother's funeral, and instead of sad or mourning, just furious with a family member for doing this to me. And that's something that needs to be discussed as well, that it's normal to feel angry, but you have to make it very clear that the intention wasn't to do something to you, that the person had a serious mental health problem that wouldn't allow them to think straight or think right, or they were overwhelmed by something going on. So that internet, nowadays, even young children have access to the internet. Whenever we want help, we go online. And one of the problems is that when you do a suicide search, even though Google and others will have a pop-up giving a number for Samaritans or some other helpline, there are sites that you can find very easily that encourage suicide or tell you how to do it. And there are people out there who look for vulnerable young people to encourage them to end their lives. There's also memorial sites where someone dies and the other kids put up a site and they all sort of put little mementos of the person. And these are not things to be encouraged because it glorifies the suicide. Children who are feeling no one cares about me might say, look, if I kill myself, people are going to put up a site like that and they're going to remember me and think about me. So it's not to be encouraged. But if you're worried about a child, you need to monitor as best you can what they're looking at over the internet. I'll take just a few more minutes. I wanted to talk about coping. I understand suicide for adults and children to be a way to cope with problems which we think are going to continue forever. We think there's no other way we can deal with them. And this is the only way I can stop suffering because of that problem. And there's a lot of research, most of it's on adolescents, which shows that adolescents who attempt suicide, when you compare them to other adolescents who are in similar stressful and problematic situations, they were bullied or humiliated, or they had a horrible loss, or they're flunking out of school, whatever it is, and you compare those who attempted suicide and those that didn't, the ones who attempted suicide can think of fewer ways to cope with everyday problems. And they use fewer helpful ways. You know, they might go in their room and shut the door and listen to loud music, and that's the only way of coping with difficulties, or keep it to themselves. So those with a larger repertoire of coping skills do better. So there are programs now that teach coping skills, coping strategies. What do we do to improve a situation, make us feel better about a difficult thing? And you know, you can do various things. You have a problem, you cope in different ways. And and there are programs, like two of them that I'm involved with, are Zippy's Friends for 6 and 7-year-olds, school program for first graders. And right now there's 2 million children in 30 countries have used Zippy's Friends, and it increases children's abilities to cope. It's around the world, not so much in the US as many other countries. And another program is called Passport Skills for Life. These are more like 10, 11, 12-year-olds. And based as comic books and exercises to understand feelings and role plays. And there's data showing that it increases emotional awareness. Children really recognize emotions better, and they cope. They have more coping strategies. In fact, even the teachers who give the programs report that they cope better in their personal life. It's just a side effect of doing the program. So overall, young children, they understand what suicide is. They're exposed to it, whether you like it or not. You're not going to be surprising them. They may not know the word, but they're exposed to it. Usually by age 6 or 7, children understand that death is irreversible, that when you're dead, you don't come back, and it's universal, everyone dies. But dead people have many of the characteristics which usually we think only living people have, like seeing, feeling, thinking, enjoying, playing, and things like that. and they develop their understanding of suicide from what they see on television and discussions with other children, and adults almost never say a word about it. So they pick it up from what they see on Netflix or on children's shows. Children's thoughts about suicide, how they think about suicide, can influence later suicidal behaviors. You know, if they see the hero doing this, when it can have an effect. Children can commit suicide, but it's rare. And when you talk, you ask children what they think about death, what they already know, and you need to correct things if they have odd ideas about what happens when you die, or about suicide being heroic or okay or painless. You have to make that clear. Children generally know when there's a suicide in the family or an attempt. They need to be able to discuss this. We should try to influence how Walt Disney and others portray suicides jokingly, and very often the heroes commit suicide too. They're surrounded by all the bad guys, and then they jump into the pit or something like that. We should pay some attention to that, and also internet sites that promote suicide, which are not controlled. You can teach coping. And I think, this is something we need to do more in schools. And I guess finally, I've talked about children, but a lot of adults have pretty immature thoughts about, what happens after you kill themselves. You read suicide notes again, they're saying things like how happy they're going to be to see this or that, or you're going to be relieved and I'll feel relieved because you're relieved. They don't think I'm going to be dead, and maybe I'm not going to be feeling relieved. I'll be dead, and dead is, dead. So, some of this pertains to adults and adolescents as well. Can I take any questions, Alan?
I'm afraid, Brian, with this audience, you'll end up with great questions that will go on, but we're going to send your slide with your contact information to everyone who attended. And I know from experience that you will respond to any questions or issues that people might have. Unfortunately, within our time limits, we're going to do it that way. But I really want to thank you on short notice for taking the time, putting the program together. And I know that there's a lot of really good advice and perspective. I got a kind of ironic chuckle when you talk, and adults can have immaturity too. One of the things that happens on the hotline, we get people called who have attempted suicide, and they go, they have the kind of Cinderella concept, and the idea, they're not thinking they're going to go into convulsions, or they're going to be in all kinds of this terrible pain or this and that. So the difference between the theoretical idea of what dying is going to be, and as you're pointing out, the practical one, is one we deal with adults all the time. And I think the other point you're making, which is, and this is one that I find most significant, how we respond to children about death and dying and suicide at their youngest ages, the point you make over and over, is going to shape how they see it as they get older. And if you look up those statistics, especially for males, as they get older, they become more and more suicidal. So that's why prevention in the work you've done is just so significant. That's why prevention is so important, because if we can address these things at the youngest ages, I guess the parallel would be sexual behavior and sexually transmitted diseases. We actually can make a difference. So sorry that we can't engage in a longer conversation. Maybe we'll set up a program just with you and invite people to engage. But thanks again so much, Brian, for taking the time.
Thanks, Alan.
So I'd like to introduce Cheryl Hall to you. Cheryl has worked close to a lifetime in the New York City Department of Education. Samaritans knows her for many, many years of collaborating and promoting professional development training. She's been on the forefront of encouraging crisis intervention and suicide prevention training for social workers and counselors and therapists and psychologists. I know from her experience in consulting with Samaritans, has frequently been the go-to person when there's been an incident, whether it's self-harming or suicidal behavior or death or homicide with the Department of Education. Before I let Cheryl address the group, I was just looking at the latest YRBS, which is the Youth Risk Behavior Survey that's done by every 2 years by the CDC, the New York City Department of Education, New York City Department of Health and Mental Hygiene. And I know these statistics, but I'm looking them over again. And these are pre-COVID statistics. So every one of these numbers is going to be increasing, I would think, a minimum of 100%. So they do a survey of New York City high schools, mental health, violence, alcohol, substance abuse. We're looking at the mental health aspect of it. 20% of students said they were bullied on school property. 11% said they didn't go to school because they felt unsafe. 12% they experienced sexual violence from someone. 7.5% experienced sexual dating violence. 10% had actual physical violence tied to romantic or personal relations. 35% said they felt sad or hopeless every day for 2 or more weeks. 17% seriously considered attempting suicide. 8.5% actually attempted suicide, and over 3% made an attempt that resulted in an injury or poisoning or overdose that had to be treated by a doctor or a nurse or a medical professional. And as Brian pointed out, whenever it comes to suicide and self-harming behavior, the numbers are always underestimated. So, and this is all pre-COVID. So I want to invite Cheryl to address us, and you have your own thoughts. I'm looking forward to you sharing. I just ask you to start out. We're just looking at statistics, but from being on the front lines of DOE, can you give us a snapshot of the real prevalence of this issue that we're talking about?
Thank you, Alan. I almost started speaking without unmuting myself. So, hi everyone. This is amazing because my people are in front of me. So a lot of my colleagues are here. My co-teachers on Saturdays are here. Some of the borough managers who help these counselors and social workers and psychologists in your audience to cope with some of these statistics that you're talking about. And I was going to start by giving, talking a little bit about what I experienced over the years, but I'm sitting here and I'm looking at you and I can't help but give kudos to all of you for all that you have gone through for this past year in terms of remote learning and video chats and telephone chats with parents and families through all hours of the day and night. The school day never ended. It continued 24/7. And on a regular day, when kids are in school, we know that when they go home, your day doesn't quite end. But when they are home and they're still in contact with you, you are still talking in your sleep. So thank you for all that you've done and all that you continue to do. This job is not easy. We have made a lot of strides in terms of mental health. But when we look at that last tier and we talk about our students who are at risk, that's where we have that terrible feeling in our gut, because we are doing school-wide interventions. We are great with that. We are increasing staff all the time, and the mayor is talking now about really putting a lot of staff into schools post-pandemic. And how do we navigate that system when we have lots more people in the school building? That's a lovely thing. But these people are not there to help with lunch duty or to help a kid get off a bus. It's about really, really grinding down and giving our students that help that they need. We have not been in their lives the same way for the past 15, 16 months. And how does a school now develop a comprehensive plan, a real comprehensive plan that says we have lots of hands in this building, and how do we have a program that really dives down and help each and every student in our building? What is that equity and access going to look like for our students? And we have lots of things in schools: school counselors, social workers, school psychologists, single shepherd. We have a social work program. We have lots of things already happening, but how does it reach all the way down to our students? And that's a question that we ask every day. And when Alan talks about the data that he just read, and those are surveys, but you know we have ORS reports. And our ORS reports are not surveys. They are incidents that actually happened. And even during this time of pandemic, the ORS reports continued. Suicide ideations, suicide attempts, and actual suicides. Our school buildings were closed, but those things did not stop happening. And as we come back to schools, as our children are in cheers in schools, we're dealing with a lot. We're dealing with a lot. It's not just the pandemic. It's all the other things in life that happened while the pandemic was going on. And yes, Alan, those numbers always are the things that sober us. On a regular day, what do we do about these numbers? How do we make a difference?
And you're bringing light to the reality of it. You know, many years ago, I did a presentation at Grace Church School for 6 to 11-year-olds on mental health, depression, and suicide. And afterwards, this 8-year-old comes up to me and says, you know, 3 weeks ago, we had one on sexually transmitted diseases. Then we had one on violence. Now we have one on suicide. He said, we're 8 years old. What do you think we're doing? And I think of the version of that with the professionals and the parents and the caregivers, which is they're inundated with so many trainings and so many guidelines. You know as well as I, every time we have a professional development conference, people want to bring focus to how they're so administratively overwhelmed with the process. So I think it's great that you're first of all acknowledging the challenges, the hard work, and that it never stops.
It never
Morning. We run a 24-hour suicide hotline. You folks are running 24-hour children emotional care and support and family care and support, and it doesn't ever end. And I think that's very important. And I thank you for acknowledging the challenges and the contributions of people.
You know, I wish Brian were on. I mean, I could listen to Brian all day, and I really appreciated what he was sharing. And I'm sure a lot of folks sitting here wish that Brian was still on, including myself, because I would have clearly given up my time to him. But, you know, I was trained as a crisis counselor back in 1988 or 89. And I remember my training, we were upstate, And we were in this lovely resort, you know, Walker Valley. It was kind of rugged, but it was really nice because we were away from the city, away from everything, and we were getting this lovely training. And on the second day of the training, the one chancellor we had who really understood mental health, really understood about what children should be getting, died. Richard Green died on the second day of our training. And the training took on a very different mode because now it became a laboratory that when we left that training in Walker Valley, we were coming back to New York City to do crisis intervention for our students. And my school building was an elementary school building. And the chancellor visited my school 2 weeks before he died. So I come back to school and I'm like, they're little kids. I don't know if they'll remember who he was. And sure enough, as I walked the halls and went from class to class, the kids were talking about Richard Green. Richard Green died of asthma. My God, we were sitting in a school building where lots of kids suffer with asthma. And that was a reality for our kids. This man, he's great, he's wonderful, he's in charge of a lot of things. He is very important. He died of asthma. What about me? I'm just a little kid and I have asthma too. What could happen to me? When I feel sick in school, I go to the nurse. He didn't have a nurse to go to. He didn't know how to take his pump. I mean, they had those questions because some of them lived that life. And it wasn't so much removed from them because yes, this man didn't work in the building. They didn't see him every day, but they knew who he was. He visited the school. He made a great impression on them because that was the type of person he was. But he died of something that many of them and family members suffer with. And this is very real for them. So our kids, no matter what the age, they know, they have experiences. You can't live in New York City and be blind to anything. You know, I felt Erik's passion when he was speaking and living in a small town and feeling like the only person. And we have students in New York City that are LGBTQ, and we have lots of things all over the place. We have Pride Month, we have all of that. And we still have students who feel very alone, very isolated.
I mean, that's a point that people make all the time. I'm from rural Texas, and I never felt as alone as I've been sometimes in the East Village of New York City, surrounded by millions of people.
Yeah.
And what do you think? I mean, you've been in almost every role in terms of responding to children and younger adults, and you've overseen more trainings than probably either one of us want to remember. What do you think is most helpful, or from the trainings you've given or observed, what is going to help frontline caregivers and health providers be more realistic in responding to things? And also, I think you have to add that self-care part to it. Well, we always say you can't help someone else if you're not taking care of yourself.
Oh, yes.
So you can take that anywhere you want.
Yeah, so a couple of things, and I'll give a nod to our union because people always talk about these big unions and their only job is to be political and to get money or whatever it is. But the UFT is almost a professional organization in terms of what they do for membership. And UFT just had a conference for school counselors. We have it every year. This was the 17th year, and it was all geared towards self-care. And for any of you who were on there, and I'm looking at Susan, and she was one of the people who presented on what she experienced during the pandemic. So yes, self-care is important, but just getting back to what it is that we need. And counselors are better trained today than 30, 40 years ago. We have school buildings that are better trained. Because when I became a counselor, talking to teachers about counseling is like, I'm in the academic part. That's all I want to hear about. And my kids are very gifted, so you don't have to come in here. And those are the kids who were most in need of what I had to give. So I think our buildings, our administration, all the powers that be above us who are in the trenches are getting it now. The problem that we're having, our challenges, is when we get to that tier of our at-risk students, we don't have enough services still. It is hard to find referrals. And when you give a referral, when you finally get that parent to say, yes, I think this is what we should do, that you're up against a waiting list. You're up against funding. You're up against insurance. You're up against a lot of things that are not so attainable. And we're talking about putting money into schools, and this is the first time that this kind of money is being put into schools. But how do we make this a whole community thing? That the school gets supported, the staff gets supported, the parents and the children get supported. How do we make schools more of a mental health community? That all statistics, lots of statistics show that children get more mental health services in school than any place else. But that's not every school. Not every school has that. Up to a few years ago, counselors shared schools, social workers shared schools, school psychologists shared schools. And when we had social workers and school psychologists in the school, their main focus was to be on a school-based support team and do assessments for children who have special needs or need special programs. But now those walls are coming down because we are hiring staff to go towards individual group counseling, making assessments. But when we have these huge comprehensive plans for our building, it happens, it looks great on paper, and then it's never implemented the right way. It's never assessed to say, how is this working? Is this good for us? What should we be looking at? How do we come back in 6 weeks to say, this was great and this wasn't so great, and how do we go another way? We can't have a plan that we made 2 years ago and we had a pandemic and we want to implement that same plan come September. These plans have to be living, they have to be moving, they have to be documents that we are living by every single day. It's not in a closet, it's not in a file cabinet, but how do we bring all of these things together and really get the help for our students and get some help on the outside for those kids who need that deeper dive.
And you and I have discussed many times the idea of the, it's become cliche about it takes a village, but, that it's not like, and we discussed this when we've done training for DOE, about being real, of recognizing, you're not going to solve the problem. You're not going to fix it. The person goes home to their family, or they go back to whatever environment they are in that may or may not be supportive. But the idea of a cross-section of members of community organizations and schools and agencies and spiritual groups and drawing and the idea, and we don't get the credit for it, but working together 15 years ago, we first brought safety planning into DOE.
Oh, yeah.
And the idea of not just giving cold referrals, but making your referrals based on communication and contact. And as Brian was talking about, seeing what the young person is thinking and learning what they are and are not willing to do and respond to, and instead of prescriptively saying, do this or do that, developing an approach and a comprehensive series of supports and referrals and resources. So if one piece doesn't work or another piece doesn't work, you still have this spectrum or spider web or whatever safety net you need. But that, even as people with tremendous experience in the field, we have to remind ourselves, there's a limits to what we can and cannot accomplish. Stop shooting for the sky and be more, if someone isn't eating and isn't drinking, all these theoretical concepts don't really matter. And a lot of the training we've worked together for DOE and community-based organizations has been what I think you and I have referred to as kind of just being reality-based. You know, what can you accomplish and what is at your fingertips? And people, caregivers tend to feel more confident if they're working from what's, for want of a better term, real.
Yeah. And the needle is moving and it's slow, but we've made a lot of inroads. We have a long way to go. But I think we're beginning to see the light, where a lot of people are believing in what it is that's being done. And hopefully that needle will move all the way to the other end where our kids have greater access, you know. I know we're running out of time, but the one thing that struck me the most these past couple of weeks is when I was watching that Chauvin trial. And there were 3 young people there who were giving, who were witnesses and were giving testimony. And when those children talked about the great guilt they felt about feeling helpless and what they witnessed, and all I could think about is when they are out of that courtroom, who is supporting these children? Who has spoken to them? And I'm sure, I hope, that the prosecution put all that in place as they were thinking, because a lot of times we only think in silos, and here's the court piece, and here's the school piece, and here's the home piece. But what did we do? What are we doing to support those young people? And those 3 young people are 3 of many more all over this city who have witnessed things in their families, in their neighborhoods, in their schools, when we talk about school shootings, and lots of other social ills that are happening. Okay, we have been traumatized like we've never been traumatized in this past year and a half. And where are our supports? Those of us doing the work, and those of us helping others, and those who are definitely in need of the help. So, I mean, this is a great beginning conversation. There is so much more to do. And again, I thank my colleagues that are sitting here, and you guys at the Samaritans, and everyone who is doing this work. I'm obviously retired, but never ever stopping working, because the passion is there and that can never ever go. So again, thank you, Alan. Thank you, Samaritans. And thank you, my colleagues. Brian, Eric, thank you all.
Thank you. I really appreciate it. And I think, again, you're saying it's an important conversation. And one of the takeaways is certainly we can't help people if we're not taking care of ourselves, and to challenge our assumptions and preconceptions of some of the points that Brian was making is, you know, you and I once discussed, we had a guidance counselor who said, well, my student keeps saying he's going to jump out the window. He says it almost every day. Is there any reason I shouldn't tell him, well, why don't you go ahead? And I remember my response, which got some looks, was, well, if he said every day he was going to shoot you, would you tell him that? He said, no, I'm not going to do that. That's dangerous. Yeah. So, you know, the idea of taking things seriously, the final statement I come up with is one from the Bronx. A kid in alternative to incarceration said, if in doubt, check it out. Better to be overly responsive than not responsive enough. And, you know, we have to always remind ourselves to use our supports and our resources and the networks. And like that's been pointed out, there are new tools. There are skills and therapeutic approaches that are being developed for even younger and younger children. And the more aware of them we are, and it's reminding me with Samaritans that we need to expand our resource guides to include more and more of these tools. And we'll draw on you and Brian and others to do that. So again, thank you so much, Cheryl. You always have so much to contribute. Sure, you're retired. No one's seen it yet, but and you're a terrible role model because I'm trying to retire and I'm not doing any better than you are. But we really appreciate it. We appreciate everyone who's taken part in this event today. Every one of these conversations could have gone on much, much longer, and We know people have a lot of questions. You had Brian's email. You've got Samaritan's email for registering for this event. If you have any question for any of the people who spoke today, just email us and we will follow up and get responses for you. Before we close, I'm actually, we very, very rarely do this, but we're going to make a little pitch. Most nonprofits have been devastated by the pandemic. Samaritans has lost 40% of its funding over the last year, and yet the demands on the services keep increasing. So it's a soft sell, but we're running a Mental Health Awareness Month fundraising campaign. Please consider going to the site. Any contribution matters, but we've been putting on several programs every month throughout the pandemic. Even if it's on Zoom, it takes work and time and staff and resources, as well as running support groups for survivors of suicide loss, as well as people who are struggling right now, and call the hotline. Hotline calls have increased dramatically over the last few months. So in any way that you feel you can participate or help or donate, we're certainly appreciate it and encourage you to do so. Otherwise, I want to thank you again for taking part. We're going to have another presentation on May 27th. It's going to be a little off the track. It's going to be called Write to Survive, WRITE, and ways that we can use writing and journal writing to help us process, whether as professionals or people who are dealing with emotional difficulties and challenges. And this program has a personal interest to me because before I came to Samaritans, I was a writer, a teacher of writing and journalism, and it's a nice opportunity to use what I learned there with what I've learned working with mental health professionals and consumers and advocates in the field. So a little off the beaten path, but we'll try something new. This seems to be the year for new things. And if you have ideas or thoughts of programs that you think people would benefit from or are interested in, by all means, we'd love to hear from you. We're building a new community these days, and we appreciate your participation and welcome your input. So have a really good rest of your day. Enjoy your weekend and take good care. All the best.